Right now, millions of women are spending thousands of dollars to fix a physical problem.
Yeah.
Well, that might actually just be a media-induced myth.
Yeah, it's a massive blind spot clinically, for sure.
It really is.
Yeah.
Because, you see these ads everywhere for cosmetic vaginal rejuvenation, right? And they promise to tighten tissues, boost your confidence, and essentially save your relationship.
All on your lunch break, apparently.
Exactly, with just a quick laser treatment.
Yeah.
But, okay, let's unpack this, because the clinical data reveals a much darker, far more complex reality.
Absolutely does.
Sometimes the feeling of looseness during intimacy has, absolutely nothing to do with stretched tissue. And trying to fix a relationship with directed thermal energy can spectacularly backfire.
Right, because we're watching this crazy intersection of genuine anatomical trauma, intense psychological distress, and a highly aggressive commercial cosmetic industry.
Which brings us to our mission for you today. We are exploring a question that dominates online search bars, but remains, totally taboo to talk about in public.
Can vaginal tightening actually improve relationships?
Exactly. And to build this deep dive, we're synthesizing a really varied stack of sources for you. We've got surgical outlines from University College London Hospitals, NHS Foundation Trust.
And clinical guidelines too, right?
Yeah, from NICE, the National Institute for Health and Care Excellence, along with ACOG and the FDA. Plus some really eye-opening peer-reviewed qualitative research from MDPI.
But we're also intentionally contrasting that medical data with the actual marketing materials.
Right, the stuff being pushed by cosmetic clinics globally. So we're looking at places like Vitality MD in Toronto, Pantee in Munich, and the Women's Health Clinic.
That contrast is so essential because before we evaluate the mechanics of the procedures, the lasers, the radio frequency, the scalpels, we really have to anchor this discussion in the severe emotional reality driving the demand in the first place.
It's heartbreaking, honestly. The relational toll of pelvic floor dysfunction is profoundly isolating.
It really is. If we look at that MDPI qualitative study on younger women dealing with pelvic organ prolapse, or POP, the raw transcripts from those interviews are incredibly heavy.
Yeah, I remember reading one from a 46-year-old woman. She just states point blank, I have lost my sex life and nearly my marriage after the depression this has caused.
And then there's the 23-year-old who noted she couldn't even date because she wanted to, quote, feel sexy, but I just can't.
At 23, this isn't just about localized physical discomfort. It's a total dismantling of sexual identity.
Right. The psychological cascade here is predictable, but it's devastating. And when we look at the StatPearls data on dyspareunia, which is painful intercourse, we start to see the mechanical breakdown of how this actually happens.
It's like with genitourinary syndrome and menopause, right? GSM.
Exactly, GSM. So with that, the sharp drop in estrogen leads to a really dramatic thinning of the vaginal mucosa.
Because it's literally losing its structure.
Yeah. You lose a rugae, those natural folds in the tissue, and local blood flow decreases, which totally compromises your natural lubrication.
So any intercourse causes these microscopic tears in the tissue.
Right, microtears. And the pain from that is severe, it's acute.
And so the brain does what the brain is wired to do, right? It builds a protective association.
Fight or flight.
Exactly. It starts viewing intimacy not as a source of connection, but as a source of trauma. The moment a partner initiates, the nervous system just shifts into this hypervigilant state.
The pelvic floor muscles reflexively tense up to guard against the pain they know is coming.
Which, ironically, makes the actual penetration even more agonizing. Because this awful, self-fulfilling neurological loop.
Precisely. And the tragedy is how that neurological guarding translates emotionally within a relationship.
It's like a physical barrier being placed between two partners.
Yes, exactly. Because to the partner who doesn't understand the complex neurobiology of dyspareunia, that physical tension and that avoidance, well, it looks exactly like rejection.
Right, the intimacy gap widens, communication just totally breaks down, and resentment builds up. So when women are looking for tightening, are they really just looking to reclaim their sexual identity and connection?
Mostly, yes. The women in these studies aren't seeking surgical intervention out of sheer vanity. They are desperately trying to dismantle that physical barrier so they can emotionally reconnect.
But, desperation is incredibly lucrative.
Oh, absolutely.
When you have a demographic willing to do almost anything to reclaim their sex life and save their marriage, an entire industry will materialize to monetize that.
And the menu of interventions we found in these sources is staggering.
Let's break down the mechanics of what is actually being sold out there, starting with the heavy surgical routes. You've got vaginoplasty, which is the mechanical excision of excess vaginal mucosa, and then suturing together the underlying separated muscles to decrease the diameter of the canal.
Right. And then you have perineoplasty, which reconstructs the scarred or torn tissue between the vagina and the anus.
Which usually happens after traumatic
Yeah.
childbirth, right?
Exactly. But then at the extreme end of the reconstructive spectrum, you have complex procedures like bowel vaginoplasties.
Wait, bowel vaginoplasties?
Yeah, these are performed at major hospitals like UCLH. It involves literally harvesting a segment of the patient's colon or small intestine, keeping its blood supply intact, and transposing it into the pelvic cavity to create a functional vaginal canal.
Oh, wow. That is a massive surgery,
It is. The intestinal mucosa provides natural lubrication, which solves the dryness problem, but the systemic risks of a surgery like that are enormous.
which totally explains the massive commercial pivot toward the non-surgical energy-based devices.
Oh.
Because surgery means general anesthesia, weeks of painful recovery, risk of infection.
And clinics know modern consumers want zero downtime.
Right, they want the lunchtime fix.
Yeah.
So we're looking at CO2 and air YAG lasers, like the Photona Intimilase that's used by the Pantia Clinic.
And radiofrequency devices, too.
Yeah, like the UltraFem 360 at Dr. Sharon Lakhani's clinic. And then, of course, the autologous treatments like platelet-rich plasma PRP shots.
So the biological premise behind all these energy devices is controlled thermal injury.
Controlled injury. That sounds like an oxymoron.
Right. But whether it's a CO2 laser vaporizing microscopic columns of tissue or a radiofrequency wand heating the submucosa to over 40 degrees Celsius, the goal is to trigger a trauma response.
So you're tricking the body into healing itself.
Exactly. The body senses the thermal damage and rushes fibroblasts to the area. And those fibroblasts synthesize new collagen and elastin fibers in a process called neocollagenesis.
Okay, so this newly formed collagen matrix theoretically thickens the walls, restores elasticity, and increases new blood vessel formation.
That's the pitch, yeah. And PRP operates on a similar, though non-thermal, trauma healing principle. They draw your blood, isolate the platelets, and inject that concentrated plasma back into the tissue.
Because the platelets release growth factors.
Right, signaling localized tissue regeneration. So the clinical mechanism makes biological sense on paper. You have atrophied tissue, and you force the body's natural wound healing cascade to remodel it.
It does make sense for specific pathologies, like treating the atrophy from GSM. But, and here's where it gets really interesting, we have to look at the pushback from within the medical community itself.
The pushback is significant.
Yeah. The plastic surgery group, specifically Dr. Alan Rosen, and the guidelines from NHS Cheshire and Merseyside highlight a massive ethical conflict here.
Because a lot of this demand isn't coming from women with severe prolapse or GSM.
Exactly. It's coming from healthy women influenced by this perfect vulva myth. Wait, if the media is giving women a complex about a perfect shape, are these clinics actually helping relationships or just profiting off media-induced insecurities?
The NHS review explicitly points to the ubiquity of online media and highly curated, often surgically altered representations in pornography.
It normalizes a hyperspecific, anatomically rare aesthetic.
And a completely unrealistic standard of physical tightness, which sets up a fascinating tension. Are these commercial clinics providing a necessary medical tool to restore function? Or are they actively pathologizing normal, healthy anatomical variations?
Because the changes after childbirth or during perimenopause are natural biological progressions. They aren't intrinsic flaws that require thermal ablation.
That tension is the defining conflict of the entire industry right now. It blurs the line between reconstructive necessity and cosmetic optimization.
And that blurred line is exactly what leads patients and clinicians into a devastating diagnostic trap, which is something we really need to focus on because the revelation from the Women's Health Clinic completely reframes this entire deep dive.
Oh, absolutely. They explicitly state that vaginal tightening is just a marketing term.
Right. It is not and never has been a medical diagnosis.
So when a patient walks into a clinic complaining of a feeling of looseness during sex, the assumption, which is heavily reinforced by the clinic's own marketing, is that her vaginal canal has structurally stretched out.
And the proposed solution is to shrink the tissue back down using one of the thermal lasers we just talked about.
But the actual pathophysiology of her symptom might have absolutely zero to do with structural laxity.
Okay, wait. If the tissue isn't physically stretched, how does a patient perceive severe looseness or a total lack of friction?
Well, one of the primary culprits is nerve damage.
Really? Just from childbirth?
Yeah. During a prolonged vaginal delivery, the fetal head descends and can severely compress or stretch the pudendal nerve, which travels through this really narrow anatomical space called Alcock's canal.
Okay, so the nerve gets crushed.
Exactly. And if that nerve suffers demyelination or structural damage, it results in sensory loss. The patient experiences profound numbness.
But neurologically, during intercourse, a complete lack of tactile sensation is perceived by the brain as a lack of friction.
Right. It feels exactly like looseness.
So trying to treat nerve damage with a tissue-tightening laser is like trying to fix a broken car radio by rotating the tires. That's the completely wrong mechanism.
Worse than useless, honestly, because it's introducing unnecessary trauma. You're altering the structural collagen matrix, but you aren't doing anything to repair the crushed nerve.
Wow. How can anyone navigate this if the symptoms are so easily confused?
It gets even more complex because the feeling of looseness could also be caused by the exact opposite of laxity.
Wait, the opposite.
Yeah, a hypertonic pelvic floor, meaning it's too tight.
Let's make sure the mechanics of this are crystal clear.
Mm.
A hypertonic pelvic floor means the muscles are locked in a chronic involuntary spasm.
Exactly. Often as a secondary response to conditions like endometriosis, interstitial cystitis, or even the psychological trauma of pain we discussed earlier.
So the muscles are constantly contracting.
And because they never relax, they suffer from a lack of oxygenated blood flow ischemia and a buildup of lactic acid. They become totally exhausted.
So when a woman with a hypertonic pelvic floor attempts to be intimate, those exhausted, spasming muscles physically cannot contract any further to grip or respond.
Right. The irony is staggering. Muscles that are far too tight fail to engage properly, which clinically presents and feels to the patient like excessive laxity.
And let's think about the intervention being proposed for that. Using a thermal laser to treat a hypertonic pelvic floor is like trying to fix a severely cramped calf muscle by holding a blowtorch to it.
It's a terrible idea.
You aren't relaxing the muscle fibers. You are just layering an acute thermal trauma response over an already panicked nervous system.
But it happens constantly because the cosmetic industry heavily relies on self-diagnosis. Patients buy the marketing, diagnose themselves with looseness, and purchase a tightening package.
We also have to account for the placebo effect here.
Oh, definitely. A prominent headline from Closer magazine hints at this debate, suggesting that some of these laser benefits for postmenopausal women might just be psychological reassurance.
Because the brain is incredibly powerful. If you invest thousands of dollars into a procedure that promises to save your relationship, your subjective perception of your own sexual function is highly likely to improve, at least temporarily.
Regardless of the actual histological changes in the tissue, which is why relying on subjective patient satisfaction scores from cosmetic clinics is so dangerous. We have to look at the objective clinical data.
Which forces us to confront a very stark reality. So, if the diagnosis I is correct, does the treatment actually save the sex life? Let's look at the data from NES.
Right, the National Institute for Health and Care Excellence. Their overview shows the efficacy is incredibly nuanced.
Let's break down the positive data first, because there is undeniable positive data here.
There really is. They utilize the Female Sexual Function Index, or FSFI, which measures 6 domains: desire, arousal, lubrication, orgasm, satisfaction, and pain.
And the clinical outcomes for appropriately diagnosed patients are undeniable. In one 24-week study looking at CO2 lasers for urogenital atrophy, the results were highly significant.
Yeah, they followed nearly 600 patients. At baseline, the average FSFI score was 15.5, which indicates severe sexual dysfunction.
But by the end of the study,
The average score jumped to 27.5.
wow. I mean, in the context of the FSFI, a jump from 15.5 to 27.5 is the difference between completely avoiding intimacy due to excruciating pain and enjoying a highly functional sex life.
And the qualitative NHS studies back this up. For a patient with severe GSM where estrogen creams have failed, the neocollagenesis induced by these lasers restores the mucosal thickness. It works perfectly for that specific pathology.
But, and this is a massive peso, but if the clinical data shows such a profound restoration of function, why is there such huge regulatory pushback? That brings us to the dark side of the NICE report.
The adverse events. And they are terrifying.
Yeah, this happens when the thermal injury process becomes uncontrolled, right?
Exactly. The NICE overview details a patient who underwent laser treatment for menopausal symptoms. Instead of restored tissue, she developed persistent worsening dyspareunia.
Literally the exact opposite of what she was trying to cure.
Right. Clinicians found a crescent-shaped fibrous band in her mid-vagina.
Fibrosis. That's what happens when the body's wound healing mechanism overreacts. The fibroblasts just dump dense, disorganized scar tissue into the area.
Which literally created a stricture, a physical narrowing of the canal. The laser burned her, and the scar tissue left her vaginal walls entirely inelastic.
She required extensive pelvic floor physiotherapy just to manage the new baseline of pain the treatment caused. And she wasn't alone. The NICE report lists patients suffering third-degree burns, chronic bladder pain.
It's brutal. They paid thousands of dollars to cure their pain, and the uncalibrated energy permanently damaged their anatomical ability to be intimate.
Which puts regulators in an incredibly difficult position. And it's why the FDA and ACOG, the American College of Obstetricians and Gynecologists, have drawn a hard line.
ACOG explicitly states that energy-based devices for cosmetic vaginal rejuvenation are not medically indicated.
And the FDA went even further. They issued a warning that these devices lack robust, long-term safety data, and the marketing is vastly outpacing the science.
They are trying to stop women from becoming beta testers for an unregulated cosmetic experiment.
So what does this all mean for you, the listener? We set out to answer. Can vaginal tightening improve relationships?
And the data gives us a deeply conditional yes.
Right. If the relationship is suffering because of a physical barrier, like the pain of atrophied tissue from GSM or structural damage from childbirth, accurately diagnosing and treating that pathology can be transformative.
Because removing the pain downregulates the hypervigilant nervous system. The couple can rebuild their intimacy.
But tightening as a cosmetic concept is not a magic wand. It cannot solve the emotional disconnect in a marriage. It cannot repair a crushed pudendal nerve.
It can't relax a spasming pelvic floor either.
And it certainly cannot cure the psychological damage inflicted by media-induced insecurities. Using these devices for the wrong reasons risks permanent fibrous scar tissue.
It requires demanding high-resolution diagnoses from specialized pelvic floor physical therapists rather than accepting a quick thermal fix from a medical spa.
Which leaves us with a final thought to ponder. We spend billions of dollars attempting to medically optimize the female body to match a youthful ideal.
But if we as a society were better educated about the completely normal, natural anatomical changes that occur due to childbirth and menopause,
would the demand for this massive rejuvenation industry even exist? Or are we increasingly using medical lasers and scalpels to treat what is actually a societal failure to accept the aging female body? Something to think about. Thanks for taking this deep dive with us.